whatever you prefer. That's why there's no protocol guidance change on that.
Okay, so anything else for Jeff? Because we're going to have to do a recap because I forgot to hit record. So before we start recapping the couple things we talked about, anything new for Jeff? Okay, Jeff, can you just, I guess, recap starting with the CPAP and the aerosol generating procedures?
Sure. You ready?
Yep.
Okay. So with aerosol generating procedures, first is we want to avoid them. So as far as nebulizers go, we want to avoid neb treatments if at all possible. If you feel you have to give a neb treatment, it's better to do that on scene before you leave or outdoors if the scene is outdoors. You want to try to avoid doing it in the back of an ambulance if you can, due to the closed space and the increased aerosolization in the back of the ambulance that then you're going to have to sit in for that ride to the hospital. Those viral particles will be everywhere. They'll be on your equipment, your clothing, things like that. So you want to try and avoid that if possible. If the patient has a prescribed meter dose inhaler, like the pump, like the yellow albuterol pump or something like that, that is preferred. Have the patient use their meter dose inhaler instead of a nebulizer treatment, if you can do that. As far as CPAP goes, CPAP is one of the highest risk of aerosol generating procedures we have. It is not helpful in this disease. The respiratory distress from this disease comes from a bilateral interstitial pneumonia pattern that it develops into ARDS. CPAP will not help with that. Even in the hospital, if we did pressure support ventilation, that doesn't help with that either. So not going to help, even though we see a patient in front of us who's in severe respiratory distress. We want to try something. We know we want to do it. It's not going to help. Non-rebreather at 15 liters and put a surgical mask over top of the non-rebreather to try and cut down on what's coming out of the exhalation port. Avoid CPAP. If you roll into an emergency department with the CPAP going, then basically you're spewing virus all around the patient, and the ER staff, as some of you have seen, if you've done this, are not very happy with you when you roll in. So try to avoid that at all as possible. You don't want to use CPAP. You want to stick with nasal cannula, non-rebreather, and then use an MDI instead of a nebulizer if the patient has one. As far as cardiac arrest goes, the protocol was released. It's out there. No transport of cardiac arrest unless you achieve ROSC or you get direct order of a medical control physician. So we've had a few cases since this went into effect where cardiac arrest patients were still transported to the hospital. One patient went into cardiac arrest on the crew en route to the hospital. Obviously, there's nothing you can do about that. That should continue to be transported. It doesn't matter what rhythm it is, whether it's PEA, VFib, asystole. If they're in cardiac arrest, they're in cardiac arrest. You want to work it on scene for 20 minutes, doing your standard ACLS. And then what I'm emphasizing is that call medical control. Don't take this decision upon yourself. I know it's hard to have those conversations with the family sometime, and it's hard to not transport the patient, and you may feel like you're not doing the right thing. But number one, the literature supports what you're doing. So even before COVID came along, in the early 2008, 2009, most of the country switched to a standard of not transporting cardiac arrests in cardiac arrest, because there is many good studies from the CARES registry, from the Ottawa protocols and AHA and all the data that's out there that's been studied, is if you don't get ROSC with 20 minutes of good ACLS on the scene, you're not going to get it in the hospital, and that there is no medical benefit to transporting a patient in medical cardiac arrest to the hospital if you can't resuscitate them. Let us take that burden away from you. Call medical control. Speak with the physician. Some people are calling and saying, well, I called and I let the charger, so I gave it. That's just a notification to the hospital. That's not. Ask for the medical control physician. Let us take responsibility for it. Let us help you pronounce over the phone. If need be, we can speak to the family members on the phone to explain what you're doing and why you're doing it. But we don't want to transport. And the few times it's happened, if any of you have been involved in those, you've seen that we pretty much pronounce the minute you hit the door. We're not working up these cardiac arrests. So that's the guidance on cardiac arrest. There may be another document coming out from the state this week on that. We sent a crisis standard of care for cardiac arrest to the commissioner. It's waiting for final approval. Hopefully that'll be out this week and gives further guidance on some of the questions that were asked about, do I intubate? Do I just do a BVM? Do I don't do either of those and put a non-rebreather on high flow and do passive oxygenation? So hopefully that will be approved and out this week by the commissioner. It was just waiting for a final approval. And those are kind of what's going on with the aerosol generating procedures, cardiac arrest. As far as an update of what we're seeing in the last 2 to 3 days at both hospitals, we've seen, as the governor has said in his press conference, kind of a plateauing or leveling off of the numbers. We're still seeing a lot of people, but it's not continuing to rise. We are seeing a few less people who come in needing intubation. So intubations are down a little bit and ICU admissions are down a little bit. We have plenty of ventilators. We got an additional 18 ventilators from the state yesterday. So we are not in need of running out of ventilators. We're not at risk of running out anytime soon. Good Sam is in a similar situation from what I'm told. So that's kind of where we're at with that. A couple of you have given me feedback, and we're aware that some of the nursing homes are still calling to transport patients that are DNR at the nursing home, right? So they're DNR, and now they have respiratory distress. Like, why is the nursing home sending them? Because we're not going to intubate them, and other than high flow oxygen and IV fluids and medications, which they can do at the nursing home, there's no advantage to coming to the hospital. We have been providing that feedback to the nursing homes. In fact, I just asked our director of case management to contact them again today. The ones we're aware of, Nyack Ridge, Northern Met, those have been pretty common. If there's other places that you're seeing this from fairly commonly, let us know and we will try to give them the feedback. You know, we can't guarantee that they're going to comply with what we're asking, but we do give them feedback and we do try to tell them to stop sending the patients, that there'd be no benefit to having them in the hospital.
Ray,
Yeah.
Jeff, Northern Riverview yesterday.
And 15 minutes ago, yes. Northern Riverview is on the list. They're a tough one.
Yes, they are.
I pronounced 2 there yesterday.
Yeah.
Hey, Jeff.
Yep.
I just have a nebulizer question for you.
Sure.
In completely non-suspected COVID patients, you know, our regular asthmatic patients, our regular, you know, just regular patients that are not COVID, are nebulizers okay? Or are you suspecting that everyone has it? And
Right. So here's the problem. I don't know what non-COVID is these days, right? There's so much community spread, and you saw it with the ship, right? In the Comfort, they were taking only non-COVID patients. Well, guess what? Some of them were positive, and now it's a COVID positive location. So, you know, it's lower risk, right? If they have a history of asthma and they're just having an asthma attack, and you don't think they're COVID, okay. But remember, COVID patients can have no symptoms. They could have very mild symptoms. So there's truly no such thing as non-COVID, I don't think right now, but it's lower risk. So if you were going to do it, again, I would still try and do it on scene. I would still, you know, wear all the PPE, you know, and follow all those precautions. But I pretty much would treat everyone as if they potentially COVID.
Jeff, I have a question.
Sure.
If we have a patient, like what we're trying to do is have BLS bring the patients down if we're being called to the nursing homes rather than going in there. Because then we have to don PPE, and if it's not necessary, we're trying to conserve it. If they bring somebody down and they code, can we do it the same way as we used to do back in the old days when I used to do transports? And if that person expires in the parking lot, you can bring them back upstairs to their room?
Yeah, that's what I would do. It's, you know, you haven't left the facility yet.
Right. So we can work it in the driveway for 20 minutes with the doors open and then say, all right, didn't work.
As far as I'm concerned, that's fine. I can't speak to what might happen at the nursing home or what kind of pushback you might get from the administrators or anything like that. And, you know, maybe Frank and I can follow up on that a little bit. But yeah, I mean, I would think that if if they're at arrest and you haven't left, that they stay there.
Frank, have bail money ready.
There's no bail anymore. Don't worry about it.
Exactly. You'll be required to be released automatically.
You get Mets tickets.
Yes.
Jeff, I have a question for you.
Sure.
It's kind of an anomaly, but the other night we had a female COVID patient who decided that she was going to party in OD. Thankfully, 2 rounds in Narcan, and we were able to get her back. In the future, something like that happens, do we just continue regular ACLS overdose protocol and work 20 minutes and that's it? Or
Yeah, if they're in arrest from an overdose, I mean, other than giving the Narcan, I would do the standard ACLS, right? And if you don't resuscitate them, you don't resuscitate them. It's not the cause of the arrest has to be, oh, I think it's COVID. It's any cardiac arrest, any medical cardiac arrest. So that's a good question, because that came up with one of the arrests that was transported also. They said, well, I wasn't sure they had COVID. How am I supposed to know if they have COVID? It's all medical cardiac arrest. It has nothing to do with whether they have COVID or not.
So let me add something. Hey guys, sorry I was a little late joining the call. We're seeing all these weird phenomenon, and it's been documented actually in some of the other places where they have a high percentage of COVID patients. But we're seeing like patients that are presenting with MIs, PEs, clogged dialysis catheters, all kinds of like thromboembolic disease is going on in the community. In patients that have COVID. So like we found a patient with an aortic thrombus, just developed a cold leg while they were in the hospital for less than 24 hours. So these cases even that are being called in with STEMIs or NSTEMIs, they definitely could be COVID. We're seeing increased thromboembolic disease. So all these cases that, they could code from a STEMI just because you do the EKG when they have a STEMI, it doesn't mean that they have not COVID. They could be COVID plus a STEMI, either independent of their COVID or because of their COVID.
Yep, we had a 31-year-old arrest last night that arrested en route that had a STEMI EKG pattern, but it was COVID.
Yeah.
Okay, anything else on, I guess, medical aspects of what we're doing? Dr. Wasserman's on now also. Any other issues we want to discuss that would involve the medical directors?
I just want to say thank you for a great job that everyone's doing. We're out there and you guys are, everyone's doing a great job. So round of applause for everybody.
Thank you. I mean, I think it's important that we all make sure. I think it's easy to get kind of down on yourself in this situation. You're probably seeing more death, just like we're seeing more death than we've ever seen, even in a given shift. And so just to make sure that everyone stays mentally sound, it's important that we encourage each other.
And if anybody feels a need for it, we do have the, I forgot what it's called now off the top of my head, but the employee counseling.
EAP, yeah.
EAP,
Counseling.
thank you.
Yeah.
At NIAC, you can just call them up and just tell them you're an employee of RPS or RMC and we have an account with them. It's confidential, nobody here needs to know or anything like that.
And then you guys got to get this stuff cleared up by EMS week so we can give you free food again.
Okay, so I had a couple other things, non-medical. Jeff and Adrian, feel free to stay on if you want to. Just recertification-wise, the state has extended everybody's expiration date or their certification expiration date 1 year, but that doesn't mean that they don't want you to submit in a timely manner if you can. So Jessica is, fantastic. She's working diligently to get everybody done. So if she's reaching out to you and trying to help you with your CME, please, extend whatever cooperation you can. I know people are working a lot of hours and stuff like that. Jeff and Adrian have agreed that we're going to turn these sessions that we're doing into medical control CME and general CME for the CME program. Jessica had a great idea that she's going to put everything up on CenterLearn. I have it right now on a YouTube channel, but she's going to put it up onto CenterLearn. And we'll have a quick, say 10-question quiz at the end of it on what we discussed. And then you would get CME credit. It would be hour for hour. It is important. Everybody today logged in with their names. I could see everybody's names, but last one, a lot of people logged in with phone numbers. So when I run a report, it's better for the state purposes if your name's there versus your phone number. But once we get the CenterLearn done, then you'll be logging in just like you always did with CenterLearn, so that won't be an issue.
Hey Frank, just ask her to give me a shout if she has any questions on how to get that done well.
Perfect, thank you. And the state is supposedly putting out some guidance this week about what that extension of your certification means. So right now they're saying that everybody should consider their expiration date, their EMT expiration date to be what it is without the 1-year extension, even though if I log into the state database, I see everybody's card's been extended for 1 year. So that's kind of where we're at. The Heart Association has extended everybody's cards for a few months. The state still has not acknowledged that. They're trying to work that out. So again, it's kind of in flux. We had a meeting last week and they had nothing really to tell us. They said they just wanted to have the meeting because they said they were going to. So hopefully this week will be a little better. PPE tracking. So Tim put in a closed call rule, I believe, on the PCRs, the electronic PCRs, as a way of tracking. So please make sure you fill that in, and excuse me one second. Please make sure you fill that in when you're finishing.
Frank, I spoke to Tim this morning.
Okay.
When you fill that in, if you put like a gown and gloves, it bumps you out of the other. So I asked him to add in a complete set box to check.
Okay. So
Rich, you have to add one for each item that you use. So if you use N95s and gowns, you have to do N95s and how many, and then add another one. And like you're doing an intervention, but add another one for gowns.
Yeah, we're not doing that.
Okay. All right. Tim said you work on that thing also.
yes, we need to make it simple. In the meantime, if anybody's having any problems.
Can I just talk on that? It is simple. You have to put it in there, or else we're not going to get stuff. So it doesn't take that long. You're just adding it. It's not very difficult.
The issue is that the county's basing the PPE they give us on the reports that Bo's doing to them. So it is very important that we have accurate numbers, because we're trying to get, PPE from the county for free versus what we're doing now, which is, we're paying for everything. So if you can, and if it's really an emergency, you could always, call us. We'll get it out to you. Those of you who've been working nights, when I come on at 7 p.m., I text everyone to see what they need, and then we run it around and stuff like that. So if you can't get in touch with an evening supervisor, then just call dispatch and they'll get you in touch with someone, because we want everybody to have the proper PPE. And it could be any.
Frank, now that that's up and running on the PCR, do you want us to stop sending out emails to troubleshooting about what we're using?
Yeah, that was my question too.
I'd ask Bo. I mean, personally, I'd like to see both until we are 100% sure it works because, of IT issues, but I'll defer to Bo
because
on
like
that.
what I've been doing is I do it on the PCR, and then at the end of my shift, I send one email with each run number of what I use.
It's been working fine. If you do it through the PCR, I get a lot of data through that every day. So if you do that, you can stop doing the troubleshooting. The only thing we would need to see in troubleshooting is if the unit needs something and it's getting really low, then put that through. But if you mark it on the PCR, it gives me run numbers, it gives me a great count. So everybody that's been doing it, it's been very helpful. I've been padding the numbers a little bit, knowing we didn't have it close call. And now that we have it close call, I can't stress enough how much you need to put that in with what you're using, because that's going to help us get, it's not even about the money. It's about, we're finding it hard to get stuff in. So if what we can get from the county through the state and feds, plus what we're ordering in, we should be able to keep all you guys safe. So it's really not a me or a county thing. It really comes down to you guys, that we have the proper stuff for you guys.
Okay, cool. Thanks.
Okay, so anything on PPE tracking or anything like that? I put out before that we were approached by a group from New City, which is, I think they said 100, or I don't remember if it's 1,000 women that are sewing these cloth face masks and giving them to the hospitals and EMS and stuff. So we picked up 200 face masks today, and we're going through them and sorting them because some of them had issues, and we'll be sending them out to the stations. That is not to be worn in lieu of an N95. That's just to go over the N95 if you want to protect the mask and extend its life, right? So it's not mandatory that you have to use it, but they're there if you want to use them, and they'll be going out to the stations. They called me after I put out the initial email on it just to remind me that those are they can be washed, in a washing machine. but they cannot go into a dryer. I guess if they go into a dryer, they just shrink and, because they're cotton and then they won't fit on your face. So those are going out there. Tim said that he added a pandemic disposition as far as the EPCR goes, so that if you have what you think is a COVID positive patient, please use that as the the ending disposition on the PCR, so that we can track the COVID cases. And that's really everything I had, unless anybody has any questions or anything else for the medical directors.
Frank, anything about doing a deep clean at the stations?
Bo can talk to that. He's got a whole project going on with that.
So we ordered in a 3-part system that we can do not only the ambulances, medic trucks, stations. That should be here, I'm hoping, by next week. And then we'll start, getting around and doing the stations. We'll figure out, how often we're going to do it. We've got quite a bit, which should get us actually way through this, and we'll probably end up doing it regularly. It took a while to find. There was so much stuff out there, and again, there's a lot of stuff that you see that I don't think it's, a lot of stuff's being pushed out there and not really knowing if it works. So we did a little bit of homework. It took us a while, and I think we have a very solid product. And as soon as we get that in, we'll start doing, the stations, like I said, ambulance, medic trucks. And I think you guys will feel a little bit better with, having that out. Just a little bit back on the PPE, what you're going to see too coming out is we've been able to get coveralls instead of just gowns. We've got quite a few cases in. They're going to be trickling in everyday cases because you cannot get like bulk orders of anything right now. We're still trying to get head coverings, which is a problem. And then if we can move into Tyvek suits, either through the county disbursement or our own, we're pursuing that too. So things are changing. You'll see everything changes when it comes out. Some things we can get, some things we can't. We find different ways. The other thing is we're going to be putting out, which we got for Ebola, which was during that pandemic, was the shields, reusable face shields, which, we can clean those, again, with the wipe afterwards and reuse it. Because again, the disposable ones are, again, hard to find. So it would be like, our goggles, we'd have to clean them, but at least, we have something that's bigger and covering the face.
Bo?
Go ahead.
I don't know if it's Stack or Dominican, but one of the local colleges is 3D printing face masks if you need more.
I know, we can, if you give me information on it, maybe we can look.
I can look. I know they posted it on Facebook. I can look and see which one did it, and we could probably reach out and ask for some.
We do have
sure it was
two other.
Stack.
It was Stack. Thank you, Linda.
You're welcome.
Yeah, we do have 2 other, I guess, groups that are making 3D face masks also. So, and I guess whatever comes in would be helpful.
Frank, one other thing I thought of, I was going to talk a little bit about the therapies we're using for COVID-19, but it made me realize one important point. So some people are taking hydroxychloroquine and azithro, and they may be doing this on their own as an outpatient, or a doctor prescribed it. I don't know where they might have gotten that idea from, but anyway, they may be doing that. Both of them are QT prolonging drugs. So if you guys are dealing with a patient that, is in VTAC, a younger patient is in VTAC, or, looks like torsades, keep that in mind, right? Because MAG is the first line treatment for that. So we're seeing case reports of some of these people going into torsades or polymorphic VTAC. So just a tip to be on the lookout for that.
We actually had a case in the ED. I was going to say, we actually had a case in the ED, a young guy who died, who came in cardiac arrest, coded while being transported. Torsades. Yeah, 50. Couldn't be resuscitated.
Hey, Jeff, back to cloth masks for a second. The World Health Organization seems to have vacillated quite a bit on this topic. What's the latest thinking about either their effectiveness or the appropriateness of their use, both standalone and in adjunct?
Not usable as standalone. They're not for healthcare provider use. They're good for people who are going out of their house to go shopping to the grocery store or wherever else to cut down on, when they cough or sneeze, the distance that they're going to spew those particles. But it's not a surgical mask. It's not an N95, and it shouldn't substitute for either of those things. But it is useful. It can maybe helpful to protect the mask that you're wearing over top of it, to keep it from getting soiled. But they're not, most of the staff in the hospital that have these masks that people have made for them, they're wearing them over top of their usual PPE.
I have some interesting articles that have been published. Some of them after H1N1, they did some research on, is a cloth mask, how does it compare to a surgical mask versus an N95 mask, and which materials are the best materials. And if you're interested in that, I can forward it over to Frank if he wants, and you can read it.
It would be great. My concern, of course, is, if we do that and we cover our N95s, is it really a false sense of security around how clean your mask is?
Yeah, I mean, well, you're running around right now without any covering over your N95. So yeah, I mean, it's gonna provide some false sense of security, but it also may cut down on the viral content or bacterial content even on the surface of your mask. It may also make you less likely to touch the front of your mask. It's very difficult to stop touching your face. You're wearing a mask, it's coming down, it's itching your nose. And so, it may also cut down on whatever your, hand to face type behaviors.
Got it. Thank you.
What else? Anything else?
Hey, Frank, I had a quick question about I don't know if anybody else is getting frustrated with the departments asking us for a one-on-one on every call. I'm assuming every patient is COVID positive at this point and taking precautions on every patient, and the one-on-one information is not useful at this point anymore. Is it worth it to try to?
Yeah. So I think that, Clarkstown was one of the first ones to initiate that. And I think early on when we just had people quarantined, that might have been helpful. But you're right. I mean, everyone now is a suspected COVID case.
It's just, for me, it's just adding to the stress level at this point.
Clarkstown has discontinued that one-on-one.
Oh,
Yeah, okay, good. Yeah, it was helpful, but I think at this point, how far it's spread, it's not helpful.
Just have to realize that there's also the volunteers. So, I mean, we can't call up the police department and tell them to stop something because it may trigger a whole,
Let the volunteers do the one-on-one then.
Yeah. So, I mean, if you don't want to call the one-on-one, I mean, I think the police are thinking they're trying to be helpful. So.
Clarkstown stopped it because they're only getting 15% callback.
Okay.
All right.
Is there anything else? Is there anything else we want to talk about? Okay, so if we're done, I'm going to post this back up on YouTube for the time being until we work out with Jessica and Jason how to get it up on CenterLearn. We had between 35 and 40 people today, so again, we had a great turnout. And the one that I put up on YouTube the other day, I think we're up to like 65 or 70 views, and that's locked down. So that's really only our own people that can view it. So it seems like this is working. I'll schedule another one for next week. I mean, unless anybody thinks we need to have another one this week, but I think unless something pressing happens, we'll schedule one for next week. Is during the daytime better for people than that evening session? Any preferences of time or anything like that? Okay, so I guess we'll try again for 2 o'clock because that seemed to work for everyone. We'll do 2 o'clock again. That works into the medical director schedules and stuff like that. And I'll coordinate with them a date next week when we could do it. So if that's it, everybody stay safe and thank you again for participating. And we'll talk to everybody next week.
Frank.
Take care.
Thanks.
Thanks.
How do I leave this there?